All right, let's dive right into this explainer on Chapter 378. We're unpacking the systemic medical mystery of relapsing polychondritis and a truly groundbreaking genetic discovery. We're going to look closely at a disease that literally attacks the structural scaffolding of the human body and how a recent scientific plot twist is completely rewriting our understanding of it. Here's our roadmap for today. First, the cartilage culprit. Then, classic clues in the ear and nose, followed by the hidden danger in the airway. After that, we'll cover ocular and systemic reach, the genetic twist of vexus, and finally, diagnosis and treatment. Section 1. The cartilage culprit. Let's start our journey at the microscopic level to see exactly what goes wrong here. So, the absolute crux of relapsing polychondritis, or RP, is that it specifically targets and destroys cartilage, that vital structural scaffolding found all throughout our bodies. It's a rare systemic condition driven by recurrent, destructive inflammation. And while the exact mechanisms are still being hammered out, one thing is crystal clear. The immune system essentially turns against the very tissues that give our ears, nose, and airways their shape and stability. Look at the stark difference when the immune system invades healthy cartilage. During an acute attack, a mixed inflammatory infiltrate just floods the interface. Over time, this causes the breakdown of the lacuna and the tragic loss of chondrocytes. Those are the cells responsible for maintaining the cartilage in the first place. Ultimately, that flexible, healthy tissue dies off and gets replaced by rigid, totally functionless fibrosis. Moving on to Section 2, classic clues in the ear and nose. Let's see how this microscopic cartilage destruction actually manifests on the outside. Notice that striking, bright red inflammation of the ear cartilage. The cartilaginous pinna is intensely inflamed. But look closely. The non-cartilaginous earlobe is completely spared. It's perfectly normal. This sharp line of demarcation is a huge hallmark clinical clue for RP. It affects roughly 80 to 90% of patients, serving as a profound visual indicator of exactly where cartilage lives and where it doesn't. Now, if these painful episodes keep happening, sometimes triggered by something as unbelievably minor as just resting on a pillow or wearing glasses, it can lead to permanent structural damage. The cartilage completely loses its integrity, resulting in that floppy, misshapen cauliflower ear deformity. It's a striking physical reminder of just how destructive and recurrent this inflammation really is. When we look at the nose, we see how a feeling of pressure and mild swelling can progressively collapse the nasal cartilage over time. This collapse creates that infamous saddle nose deformity. What's really key here is that in relapsing polychondritis, this deformity usually happens without the septal perforation that you typically see in similar autoimmune diseases like granulomatosis with polyangiitis. In RP, the damage is purely to the structural cartilage itself. Section 3. Hidden danger, the airway. While those external deformities are distressing, we need to transition to the most imminent, high-stakes danger of this disease. It's honestly a terrifying thought, but we have to ask, how does a patient breathe when the very structural rings keeping their trachea open literally begin to melt away? Our airways are heavily dependent on those cartilaginous rings for stability, which makes them a prime, incredibly vulnerable target for RP. This clearly shows subglottic stenosis, which is a severe, life-threatening narrowing of the upper airway. This inflammation can flare up acutely, causing a high-pitched breathing sound known as stridor. Tragically, because it often presents as just breathlessness or a cough, it's frequently misdiagnosed as adult-onset asthma. But in reality, it requires urgent, life-saving medical intervention to keep that airway open. Looking deeper down, these computed tomography scans brilliantly illustrate the hidden destruction, tracheal calcification, and lethal tracheomalacia. This is where the cartilage of the lower airways gets so weakened that the airways just collapse entirely during exhalation. Patients might come in with intermittent episodes of wheezing. That's exactly why any suspected RP patient absolutely must be closely evaluated for this deeply hidden, potentially fatal airway damage. Section 4. Ocular and systemic reach. Beyond the respiratory tract, relapsing polychondritis acts like a systemic medical detective case. The sheer systemic reach of RP is vast, leaving clues across multiple organ systems. It can cause a non-erosive inflammatory polyarthritis, very often in the knees. It can hit the ribs, causing costochondral joint pain that is so intense it frequently mimics a cardiac event, sending patients straight to the ER. In the eyes, it can cause episcleritis or even a deeper, dangerous scleritis that carries the catastrophic risk of globe rupture. And in the inner ear, we're talking profound conductive or sensory neural hearing loss and dizziness. Section 5. The genetic twist, VEXAS. Now let's see how all this builds to a massive scientific paradigm shift. For decades, severe, highly inflammatory cases in older men were just labeled as aggressive, treatment-resistant relapsing polychondritis. But now, we know they are often VEXAS syndrome. This is an incredible discovery. VEXAS stands for vacuoles, E1 enzyme, X-linked, autoinflammatory somatic syndrome. It's essentially an acquired somatic mutation in the UBA1 gene that masquerades as a rheumatologic disease. It isn't something you're born with, it's an acquired mutation in the bone marrow, driving this intense systemic inflammation. The crucial differentiator to look out for here is the hematology. When you see a patient with recurrent ear and nose chondritis, but they happen to be an older male presenting with macrocytosis, lymphopenia, and bone marrow failure, that is a massive red flag. It tells clinicians they need to stop thinking about classic autoimmune RP and immediately pivot to genetic testing and bone marrow assessments for VEXAS syndrome instead. Section 6. Diagnosis and treatment. Having identified the culprits, how do clinicians actually crack the case and stop the inflammation? Because we still lack a single definitive blood test or diagnostic biomarker, doctors rely heavily on clinical pattern recognition. They use historical frameworks like McAdams or Michette's criteria to formally establish a diagnosis. McAdams requires seeing 3 out of 6 classic symptoms, like bilateral auricular, nasal, airway, or ocular chondritis. Michette's, on the other hand, allows for a combination of 2 major criteria or 1 major and 2 minor criteria, like hearing loss or arthritis. It's really all about connecting those diverse systemic dots. Once the disease is suspected, a comprehensive diagnostic workup is absolutely essential. You have to move step by step to catch that hidden damage. We're talking audiology to assess hearing loss, dynamic expiratory chest CTs to check for that vulnerable airway collapse, echocardiography to evaluate the cardiac valves, and even PET scans to find hidden inflammation in the large vessels. You literally have to map out exactly where the disease is hiding in the body. To fight back, our medical arsenal is pretty diverse. High-dose glucocorticoids remain the rapid-acting, life-saving cornerstone to quickly shut down acute flares. But for long-term management, modern medicine utilizes targeted therapies like methotrexate, leflunomide, TNF inhibitors like infliximab, and anti-interleukin-6 therapies. And crucially, because this disease attacks so many different systems, managing it absolutely requires a tight-knit multidisciplinary team. Think rheumatology, pulmonology, and ENT all working in sync. As we wrap up this explainer, I want to leave you with a rather provocative thought. If a classic autoimmune disease, one we thought we completely understood for decades, turned out to sometimes be a somatic genetic mutation in disguise, what other medical mysteries are just waiting to be decoded in our DNA? Thank you for exploring the fascinating and sometimes hidden complexities of relapsing polychondritis and VEXAS syndrome with me.